Hello everyone, I am Dr. Ajit. I secured All India Rank 3 in the last NEET SS exam for DM Oncopathology and
myself, Dr. Munishwari. I secured All India Rank 3 in the INISS DM Hematopathology exam.
we are doing this video because we have launched a course for DM Oncopathology aspirants as well as DM Hematopathology aspirants.
Not only for aspirants, this course is also useful for the pathology residents because during our UG times we don't have much exposure to the actual patho work that we are supposed to do in the during the residency time.
Yeah, that's true. That's true. In the residency only we have to deal with lot of crossings. We have to see lot of slides, and we have to remember a hell lot of terminologies. The learning curve of pathologist is definitely very steep.
And even after the residency is completed, cracking these competitive exams, that too managing our routine job, it will be difficult even if you don't have any proper guidance.
Yeah, and for all these reasons, we are launching this course, which includes the course for DM Oncopathology aspirants, where I will be dealing with the major portion, the surgical pathology part, and whatever hematopathology part that is needed will be dealt by her.
And I'll be dealing with the DM Hematopathology course where we'll discuss the core concepts of each hematopic and the corresponding surgical path will be dealt by him.
And for PGs exclusively, we have combined the oncopathology as well as hematopathology, and we have created this course, PG Masterclass.
And at the end of the day, it doesn't matter how much you read unless if you don't do your self introspection. So for that, we have created this Elite Q Bank series where you can do topic wise questions.
Not just the questions, we have also included the grant test, timely grant test, so that they can tackle the fear of the exam.
And so after this, we are posting the demo videos for both the oncopathology and the hematopathology. So you can get the idea of how this course will be.
So let's learn together. Hope you will like our course. Thank
Thank
you.
you.
The parody told the surrounding adjacent lymph node, hey lymph node, you are single, I am single, right? There is no capsule. The capsule of my parotid gland is not yet developed. Why is it single? Please, let's just mingle, right? Lymph node and parotid kind of mingling. And you know what is the result? What is the result of this mingling? The result is that in case of a parotid, inside the parotid, these are the parotid, right? Parotid. In the parotid, we are getting these lymphoid follicles, right? The same exact lymph node kind of structure inside the parotid. That's the intraparotid lymph node. And inside a node, can you see the capsule having lymphoid structure? I'm getting serosacini, bland looking serosacini, right? It is nothing but an intranodal parotid. Is it normal? Yes, it is normal. Because they just mingled. Either it is a sebaceous lymphadenoma, or this lymphoepithelial cyst, or this Wardens. They are a result of mingling of this parotid and lymph nodes. Now you understood why there is a close oppose of lymphoid and epithelial structure. One thing. Another thing is that these three lesions are quite exclusive. Not lymphoepithelial cyst, but these lesions are quite common, very common in case of parotid. This different kind of spindle cells. Either it can be a fibroblast or myofibroblast or smooth muscle. Fibroblast having tapering end. The background is, because it's secreting collagen, the background is little bit fibrillar kind of. Whereas in case of myofibroblast, the cells are active in the sense that they have to secrete more protein. That's why they need more mRNA, and more of endoplasmic reticulum. And those nucleic acid, the mRNA, the nucleic acid is what is taking up the hematoxylin chain, giving a basophilic color to the cytoplasm of myofibroblast. And regarding the nucleus, of course, they are euchromatic because they are again active cell. They have to secrete collagen. That's why they are opened up, having a prominent nucleoli sometimes. Regarding smooth muscle, I told how the cigar shaped ends are helping you and how the homogeneous eosinophilic cytoplasm is helping you, rather than the cytoplasm containing collagen fibers in case of fibroblast, right? And of course, this is a transverse section. Once you see a transverse section, you need not confuse that it's not a spindle cell or it's not a soft tissue. Spindle is a mesenchymal tissue. Just by seeing the round or overt cells, they're still a spindle cells, just cut transversely, isn't it? Okay. And of course, the neural tissue having a buckling end, having a wavy kind of nuclei. Of course, with a fibrillar cytoplasm, that's kind of a neural tissue. And endothelial cells, although spindle, but they are still embedded in the basement membrane, quite attached to the basement membrane. That will help you. It's an endothelial cell. Fine? Okay. Divide the prostate, right? Transfer section like this. But here comes the point. In case of base, right, and in case of apex, can you see base and in case of apex, there is a different kind of division. The division will be radial. Can you see this kind of division, radial? Further division, I mean the second division. After cutting this is the second division. So that the result will be like this. We want to see how it is going to the bladder neck, right? Because in prostate, while reporting, we have to give bladder neck margin, bladder neck resection margin, right? And this prostatic apex is nothing but attached to the bladder neck. That's a margin. That's why we have to give radial, cut section of the apex. Similar to the base, radial. Rest all, you just give a slice and you have to level it. I hope you know how to level it. Many don't know how to level it. Leveling will be like this. Say, I'm drawing it. Anterior, posterior, right lateral, left lateral. Clear? Now, if you are putting a cassette, this cassette, if you are using this area, say this area if you are using. So, you level it. How will you level it? Say in A1, you are putting that area. It will be left, right, anterior, posterior, anterior, lateral. So, I will write left, anterior, lateral, LAL. In fact, short forms are used nowadays, right? If I am using this area, you tell me, what is this? Right, anterior, posterior, lateral or medial? Lateral, right, posterior, lateral. Clear? Nothing medial is there. Left anterior lateral, right posterior lateral, right anterior lateral. You can name them, right? Believe me, while embedding the whole prostate, the cassette number will be around 30. If you are doing it perfectly. Once, surgeon cut this end, the urethra, this area, the urethra will retract, right? Urethra is retracting. And if urethra is retracting, believe me, it will go inside. It cannot be in same plane, right? So ideally what you should do, you should give this much, the skin cut margin and all you can give in one plane, cavernosa cut margin. But urethral cut margin has to be given in different cassette because it cannot come in one plane. If you are cutting in one plane, that means you are going bit deeper. You are not giving the actual margin because urethra is deeper. You are not giving the actual cavernosa margin. You are cutting bit deeper and you are giving. Epididymis is involved, stage is different. Epididymis is not involved, stage is different, right? So we are supposed to always cross the head of the epididymis. Then I searched the literature and I found that there is also a clinching point to know whether the epididymis is from the head end or the tail end just by this picture. Can you see this? This is also an epididymis and this is also an epididymis. But this is from the head of the epididymis and this is from the tail of the epididymis. Now you tell what is the difference? You will be telling me what is the difference. You say in head end of the epididymis, there will be, if I can write it, there will be clear cells, right? There will be apical mitochondria, right? Of course, apical mitochondria you cannot see, but at least you can see some sort of granularity in the apex of the clear cells. That's the head end of the epididymis. But what my faculty saw in that slide, where we have crossed this area is nothing but this structure. What is the structure? Yes, intranuclear eosinophilic inclusions, right? Can I write it? Inclusions, intranuclear inclusions, right? And these inclusions are characteristics of tail, right? I will tell you a mnemonic. A refers to under, right? A for under, inside. So when I say T4A, we are referring to involvement of chest wall. And when I say chest wall, I am referring to involvement of intercostal muscle. I am not referring to pectoral muscle. This is one of your MCQ. Pectoral muscle involvement doesn't make it T4A. It has to be intercostal muscles. What about T4B? T4B, B for Bahar, right? Bahar means outside. So it is involvement of the skin. Okay. C refers to combined A and B, A plus B. D refers to inflammatory breast cancer. Don't be misguided by the term. It's a misnomer. Inflammatory doesn't mean that it is rich in neutrophil. It refers to the presence of both clinical finding and pathological finding, right? Now, clinical finding, there has to be more than 1/3 of the breast specimen edematous and erythema. Why it is edematous? Because the lymphatic is not drained out. Why? Because of blockage of the dermal lymphatics by tumor emboli, and that's what you see in pathology. Dermal lymphatic emboli is what you see in pathology. But if there is some intervening fibrostic area in between these two metastatic deposits, what are we going to tell? In DNM, it says that while staging N under DNM, you have to consider the largest metastatic deposit only. But when we consider RCB, it tells that the intervening fibrotic area has to be considered under the dimension. So what is the complete dimension? It's the metastatic foci along with the intervening fibrotic area. So intervening fibrotic area is not concerned. It's not considered. Let me write it for you. Intervening fibrotic area is included under RCB, but not under DNM, right? In the last NEET assess, they gave a question. Let me write here, NEET assess. Yes, they gave a question. They gave the picture, this picture, not this, actually a clear cell RCC. That was quite easy to diagnose. And in the question, you know what they asked? They gave a scenario. They told that there is a renal tumor. The renal tumor image they have given, right? And they told that there is a cutaneous lesion also, right? I'm writing here cutaneous tumor, right? There was pulmonary cyst. They told pulmonary cyst, right? So a cutaneous tumor, right? A pulmonary cyst and a renal tumor. Now, if I'm not showing you the clear cell RCC picture, believe me or not, you all would have told the diagnosis is Birt-Hugh syndrome. Heard of it? Birt-Hugh, right? But many of you will tell, but Birt-Hugh, we already have learned in our PG classes that Birt-Hugh is known to be associated with chromophore, right? It's known to be associated with chromophore. Now, I was in a dilemma in my examinations. Like, they have given a picture of clear cell RCC, but the description what they have given, renal tumor, cutaneous tumor, pulmonary cyst, everything is matching with Birt-Hugh. Now, in the options they have given which syndrome is associated, which is quite probably associated with this history. They gave number 1 VHL, number 2 Birt-Hugh, number 3 Cowden syndrome, number 4 SDS deficient RCC, something like that. Now, you tell which one you would mark. Anyone? So what I did, that was a mistake I did. I did that question wrong, right? That what I did, that okay, fine, it is a clear cell RCC, it is associated with VHL. So I mark VHL. There I committed a mistake, right? Whenever I am telling that clear cell RCC is associated with VHL, doesn't mean that it is not associated with any other syndrome, right? Clear cell RCC can occur in Birt-Hugh syndrome. Clear cell RCC can occur in Cowden syndrome. Clear cell RCC can occur in SDS deficient RCC also, right? It can occur in any other syndromes also. If other features are matching with that syndrome, answer here in the NEET assess has to be Birt-Hugh. It's not VHL. Okay, what about Amaker? Amaker will stay luminal or basal cells? You tell me. Luminal, but definitely luminal, but only in case of malignancy, right? In case of malignancy, it is staying. And in fact, nowadays they're asking different name of the ISCs. Like last time they asked, what is the I'm telling you a new prostatic marker they asked. That's the question again, NEET question only. They asked what is the another name for prostin. They don't ask what is the new prostatic marker. They ask what is the another name of prostin. You need to know that it is a new prostatic marker and another name is P501S. That was a NEET assess question. Last NEET assess question. Clear? Similarly, they can also ask this time or the next time, what is the new name for Amaker? Right? The new, see, this is P501. That's why I thought I should include that. This is, I'm writing here, should I write here? P540S. 540. 501, this one, this is 540. Remember? That might be another question. And regarding the basal cells, if they'll ask you what is the marker, you will tell basal cells, of course, I know that P63 is the basal cell marker. Of course, high molecular cytokeratin like CK5/6, like CK903. Also, another name, just knowing CK903 as a high molecular weight cytokeratin won't do. I already have discussed CK in great detail in breast lecture. You can see that CK903 is nothing also referred to as, shall I write it? 34 beta E12. They can give this also. They will ask you, basal cell markers are all except number 1, P63, number 2, CK5/6, number 3, CK903, number 4, 34 beta E12. They are all answers of the markers of basal cells, right? Clear? The cribriform of intraductal carcinoma, can you see this punched out, sharp lumen, enclosing whole of the duct, whereas cribriform here is not punched out. It's kind of a bland, irregular lumen, kind of a slit like somewhere, right? It's not punched out. Loose cribriform. That's why I use the term loose cribriform. Yes, if you are getting this and you're not getting necrosis and all, please don't tell it is, high-grade PIN. Please don't also tell that it is intraductal carcinoma. I want you to tell that it is AIP. What is that? Atypical intraductal proliferation. Atypical intraductal proliferation. You know why? Why? Because if you say high-grade PIN, of course, high-grade PIN you won't report at all. Intraductal carcinoma, they will ask for a repeat biopsy, right? If you're writing atypical intraductal proliferation, that depends upon the surgeon. The surgeon will correlate with prostate, the levels. They will follow. They will do surveillance. They will follow up the PSA level. If it is subsiding, they won't do. If it is not subsiding, they will go for repeat biopsy. So reporting this is important, right? In fact, some surgeons also warrant immediate biopsy if you go for AIP. Fine. So reporting is important. Terminology is important. Don't use vague terms by yourself, right? You might invite legal issues. High-grade PIN, atypical intraductal proliferation, and intraductal carcinoma might look same spectrum, but they have subtle differences that I told you. Fine. Molecularly defined renal carcinomas, a separate group, which is I will say highlight in the new WHO, in the 2022 WHO classification, is the molecularly defined renal carcinomas, which include TFE3, TFEB. Previously they were under same group, MITF category. right? ELOC mutated, fumarate hydratase deficient RCC. Previously, it was referred to as the same entity only. It was under hereditary leiomyoma and renal cell carcinoma, and now it has been given the particular enzyme, fumarate hydratase. Similarly, succinate dehydrogenase deficient RCC, all clearance RCC. So this is, I believe, this is the highlight of the new WHO, and definitely a potential MCQ for your DM Oncopathology or Histopathology or Hematopathology exams, whichever may be. And another entity which I wanted you to focus is regarding these neoplasms, regarding the mesenchymal tumors. See, previously WHO in 2017 was including every mesenchymal tumors which are not specific to the renal site, like leiomyosarcoma, angiosarcoma, rhabdomyosarcoma, one from smooth muscle, one from vascular origin, one from skeletal muscle origin, right? Even synovial sarcoma, Ewing sarcoma, all those things, they do occur in kidney, right? But the current WHO, what they have done, see, under renal mesenchymal tumors, they have omitted all those things. They have omitted everything. They have just kept few mesenchymal tumors which are quite specific to renal site, like angiomyolipoma, epithelioid angiomyolipoma, right? Renal hemangioblastoma, which are something, which are not that common, right? That are quite specific to the site. That only they have kept under renal mesenchymal tumors. Rest all like hemangioma or angiosarcoma or whichever, leiomyosarcoma, rhabdomyosarcoma, they have omitted. Want to know the morphology of myoepithelial cell, please see the pleomorphic because pleomorphic myoepithelial cells can be spindle. Can you see the spindle? Spindle, right? Or it can be plasmacytoid, frank plasmacytoid myoepithelial cells. It's a metaplasia only. Or can you see the myoepithelial cell kind of producing a osteoid matrix, osteoid metaplasia? Or can you see this thing? What is this thing? What is this thing? Yeah, if you can find it, tell it. Yes, it is nothing but squamous metaplasia. Even squamous metaplasia is quite common in pleomorphic adenoma. That everyone knows. What's the big thing in that? Big thing is, for a beginner, if squamous metaplasia is extensive, right, you can confuse them as squamous cell carcinoma, or if you are a bit mature than a beginner, you might say it's a salivary gland, it's a mucoepidermal carcinoma. But squamous cell carcinoma obviously is not a biphasic. You won't get any myoepithelial ductal every component. So that obviously you can rule out. But mucoepidermal carcinoma, believe me, one point, even Fletcher, even WHO also write that overt keratinization, epidermal word is used, but overt keratinization, if I'm using overt keratinization, keratin pearl formation, these are never seen in mucoepidermal carcinoma. They can be seen in pleomorphic adenoma. Next time you are seeing a keratin pearl, overt squamous metaplasia, it's a pleomorphic adenoma. Or otherwise, if you're not getting that, mild intermediate squamoid kind of cells, then definitely mucoepidermal carcinoma is a DD. Fine. Another peculiar finding I deliberately kept here is regarding this. What is the structure? Yes, what is the structure? A kind of a flower step structure in the FNAC of pleomorphic adenoma. Yes, these are tyrosine crystals. They are in fact produced by the metaplastic myoepithelial cells. In case of a pleomorphic adenoma, more of a found in pleomorphic adenoma. Definitely can be found in many other conditions, but yeah, tyrosine crystals are also been described in case of pleomorphic adenoma. Again, the pseudocyst, the morphology where the pseudocyst, this is nothing but the stroma. Again and again I'm telling because you should not make that mistake. I am telling because I used to think that it is a cyst and some secretions. Nothing. The same stroma is kind of entrapped here. Same stroma. So the lining, again and again I am telling, the lining will be, this lining will be P63 lining and not a CD117 lining. Clear? And if you are doing a FNAC, believe me, you are getting hyaline globules. You will say it's a adenocystic carcinoma with surrounded by these cells. And of course, these cells, they say that these will be kind of an angulated myoepithelial cells. Little bit atypical. As compared to the monomorphic basal cell adenoma cell, they will be little bit atypical. Angulated myoepithelial cell is found in FNAC of adenocystic carcinoma. And these hyaline globules are quite characteristic in case of a Giemsa state. But if you are doing a pap smear, and you might not get the characteristic stroma. That's kind of a pitfall in case of pap smear, in case of adenocystic carcinoma. Clear? Should be clear. And the ISCs, I already told you, this stroma, pseudocystic spaces lined by P63 and not CD117. But of course, CD117 will be diffuse positive in other cells. I will just kind of summarize few terms which I used to get confused in my residency. Clear cell tumor, clear cell sarcoma, clear cell carcinoma. What is this? Clear cell tumor, it is nothing but, tell with me, picoma, perivascular epithelioid cell tumor. So what will be the marker? It will be a myomarker and melanocytic marker, right? Melanocytic marker, SMA-HMB. It's just a picoma, right? Or you say, remember the sugar tumor you get in lungs, right? The same clear cell tumor, picoma. You can get in not lungs, you can get in any other sites. Clear cell sarcoma, if I tell, it's nothing but melanoma. If I can write in different pain, melanoma of soft tissue, right? Now, if it is a melanoma, which IC will be positive? HMB40 will be positive. Yes, it will be positive. But SMA will it be positive? Not at all. Why is SMA will be positive? Rather, S100 will help, right? Regarding clear cell carcinoma, you tell me. Clear cell carcinoma now just we discussed. It can be either in salivary. Just now we discussed in salivary we have hyalonizing clear cell carcinoma. Say kidney. If I will say kidney, we have clear cell RCC, right? Clear cell carcinoma. We can also have this clear cell carcinoma in case of other entities. Say gynae. Like in gynae we have clear cell carcinoma, right? The same. The hobnailing, the hyaline globules, HNF1, beta, napsin A. The same gynae clear cell carcinoma again can be confusion. So clear cell, you must not get confused now, right? ADPKD, tell me, you are talking about hepatic cyst, adult, autosomal dominant, fine, and enlarged kidney. You are talking about childhood polycystic kidney disease, it's ARPKD, and ARPKD surface is smooth, and it's 90° to the surface, cyst at 90°. Medullary sponge kidney, that is a different entity. My medullary sponge kidney is nothing but due to disruption of ureteric bud. Disruption of ureteric bud. Right, at the metanephric interface, metanephris and ureteric bud will combine, right? And if there is a disruption of ureteric bud at the interface, don't you think the cyst will be at corticomedullary junction? Yeah, there will be cyst in the corticomedullary junction. Fine, clear? Nephronophthisis, already the cyst is in the again corticomedullary. Already I told you. Multicystic renal dysplasia, just now I told you. Defect in BCL2. Tell me, BCL2. There can be immature mesenchyme, like cartilage can be seen, right? Acquired renal cystic disease, a chronic dialysis patient or a diabetic patient, end-stage renal disease can get this. Simple cyst, just a normal cyst, a benign cyst, completely normal. Incidental finding also may present with isolated microscopic hematuria if it ruptures. So that can be there. So that's regarding the cystic disease of kidney. Clear? Definitely can be an MCQ. Pictures, tell me, ADPKD. So after decalcifying, right? Your job is not over, right? Once you put it in the decalcifier, your job is not over. You have to look it daily. Is my decalcification is done or not, right? Because if you are putting it in the decalcifier and coming back after 7 days, you might be over decalcifying the tissue. You might be damaging the tissue. You must be harming the tissue. So for that, we have to know where is the endpoint. What is the endpoint of any decalcification, right? And that is measured by various methods. Can be physical, can be chemical, can be radiography, right? Radiography, of course, and I'm sure that it's not used in 99% of institutes. Why? Because of course, it's not possible to have a radiography technique always in your grossing session, right? And regarding the physical method, this is used mostly, very common, most commonly used. It is used. How you do that physical methods? Of course, it sounds crude, but we take a pin and we just we poke that tissue, and we see if any hardness is there or not. But the drawback, of course, is that it will create any false positive. If I can say, it will create false positive microfracture, right? Microfracture of clavicule. It can create, but obviously when we are giving, say, when we are grossing a mandible specimen, or when we are seeing underlying bone, or for seeing a margin, if it is tumor free or not, even if these microfractures, that is allowed, right? We are not concerned about the other morphology. We just need to say whether it is involved or not. In that case, we can use the physical method. In fact, it is the most commonly method used. But the next method, which I have written here, is the most commonly asked method, asked in the Viva, asked in the MCQ. Chemical method of decalcification. Now, what is the chemical method of decalcification? Okay, in the chemical method of decalcification, right? What chemicals we are using? Well, what decalcifier you are using? Suppose you are using some formic acid or whatever, some acid decalcifier you have used. Now someone is asking you that, okay, you have a bone here. Let me draw a bone here. Okay, there is a bone. Yeah, there is a bony piece here. Now tell me if decalcification is complete or not. If someone is asking you, how to tell, right? What you will do? You take 5 ml of this decalcifying fluid, right? It is an acid, right? Add ammonia drop. Why ammonia drop? To neutralize, so that it will not hinder your reaction. We just need to neutralize any acid. So it is an acid. That is an acid. So you added ammonia, which is strong alkali, right? After that, put some oxalate solution. Any solution, oxalate, ammonium oxalate, whichever, any oxalate solution. Now you see, keep this container for 30 minutes, undisturbed for 30 minutes. If you are seeing some precipitate is formed, that means some calcium, some unionized, if I can say, some ionized calcium was there. See, ionized calcium was there in this acid, still there in the acid, that combined with this oxalate to form a precipitate, right? What does that mean? That means decalcification is still going on. Decalcification is not complete. That's the interpretation of seeing a precipitate in your test, in the chemical test, also referred to as oxalate test. Yeah, this test is also referred to as oxalate test. If you are getting a precipitate, that means decalcification is not complete, right? You have to wait more. If you are not getting a precipitate, no precipitate, then that means decalcification is complete. Fine, clear? I think there should not be any doubt. Just take some acid, neutralize it with ammonia, and you add some oxalate. You get a precipitate. Decalcification is still going on, man, because there is ionized calcium. That's the evidence that decalcification is still going on. It's not complete. Fine, that's the oxalate test, rarely used. And now that we have understood how to decalcify, how to test the endpoint of decalcification, everything we discussed, I will tell you some artifacts we get after decalcification. After to be specific, after improper decalcification, right? This is one decalcification. Here we received a bone, right? right? We're supposed to fix it, right? We're supposed to fix it. But the grosser thought that why to fix it? Already it is a bone, right? Usually we have an idea that we fix it to make the tissue hard, right? That's we have an idea. Already the bone is hard, right? Why to fix it? Let's directly cut it and put it under the decalcifying agent, right? This was thought by a grosser. Now after decalcification, this was the result. Now what is this result? Can you see this nuclei? Yeah, these are smudgy, right? Having a smudgy end. These are the nuclei. That means there is there is definitely poor cellular preservation, right? What else? What about the vacuoles? What about the vacuoles? Yes, these are the vacuoles. The moment a beginner see it, believe me, you might jump onto a diagnosis of signet ring tumor, right? Metastatic signet ring cell carcinoma, just from a low power look. Why? Because what the grosser did, the grosser has skipped this step. The grosser has not fixed. The grosser has just put the bone directly into decalcifying agent. That resulted in poor cellular preservation. That resulted in artifactual, if I can write it here, artifactual vacuolations, which will resemble a signet ring cell tumor, right? And so that's the importance of knowing the importance of fixing in case of a bone tissue. Okay, here in this case, if I can tell you an history that the specimen was in decalcification for say around 7 to 10 days. Over decalcification. If there is an over decalcification, what you will be getting as a result is that everything will look everything will be looking eosinophilic. The nuclear and cytoplasmic details cannot be discerned, right? That means there is that suggests that there is an over decalcification. That occurred with me also with my faculty. I remember Dr. Suvindu sir, he asked me, he just, the moment he saw that, he said, hey, they have decalcified, go and ask the technician to give a good section. I went there, I told that sir is asking for a good section. They told, okay, good section means what? Already you have over decalcified the tissue. You should have checked the decalcification has occurred or not. Now you are asking me for a good section. How can I give a good section? I went back to sir, I asked sir which good section, I don't know how to give a good section they are telling. So sir told, I just tell them to give more time in hematoxylin, right? More time in hematoxylin. That day I realized that if a tissue is over decalcified and if the nuclear and cytoplasmic details are not discernible because it is not taking hematoxylin, please give more time in hematoxylin in an over decalcified tissue. Believe me, the results will be very nice. You will start seeing the nuclear details. You will start seeing the purple color coming out. That's what we need, right? When we say nuclear detail. So in an over decalcified tissue, I want you to take this message, right? Ask your technician to give some more, to keep it in hematoxylin for a little bit more time. Okay, again, this artifact, if I can tell you this here, wait a minute, yes, this purplish structure, irregular fragments of cortical bone or amorphous pink purple tissue, if you can see here, amorphous pink purple tissue lying here somewhere, and these are nothing but bone dust, right? But if you don't know about this artifact, what you will do, the moment you see this granular debris and pale granular debris, definitely you might confuse it with necrosis, right? And necrosis is something will take your diagnosis, take your differentials somewhere else towards the aggressive malignant lesion rather than the benign. But these are nothing but because of the bone dust. Now, bone dust may come from the iatrogenic when the surgeon is cutting the tissue, or from your side when the pathologist is cutting the tissue. Because if you are using excessive strength and you are not washing the tissue, definitely bone dust will deposit. And if you are getting a section, you might confuse them as necrosis. So that's something we need to be careful about. That's it regarding the artifacts we get in a decalcified tissue. But there are some conditions where we must not decalcify the bone. What are those conditions? That is an MCQ. What are the conditions? Yes, those conditions where we want to see that if calcification is there or not, how much calcification is there, if it is there, how much calcification is there. Yes, that condition is nothing but metabolic bone disorders. Mind it, if you are dealing with metabolic bone disorders, never put the tissue in decalcification. Then how to cut it? How to cut the bone? You can use resin-based method, various resin-based method like methyl methacrylate, epoxy-based resins, that is available, right? That as an embedding media. Or in case if it is a small tissue, say in a biopsy if you are getting without decalcifying also, you can use this rotatory microtome with tungsten carbide bed, right? Or we will read in the microtome classes, sledge microtome, right? That is designed to cut the hard tissues. That can be used to cut the bone without decalcification. In which disorder? The answer is metabolic bone disorder. Never forget this question. Very important Viva question, very important MCQ question.
And this is the typical cell of G6PD, right? Everyone knows this, which is bite cell, right? This is bite cell. So I want to clear one concept to everyone here. Even including myself, I used to think the bite cell means like, these RBCs will go to spleen, and the splenic macrophages will take up the denatured hemoglobin as in the form of a bite, and these bite cells are created. But that is not the actual concept. So the actual concept here, this is the I want to see this picture. See, can you see this is a Leishman stained slide? So can you see here the arrow pointed ones? Can you see small layer, membrane kind of thing here? This is the RBC. Here this is a stained one, and you can see a small membrane here, and here also you can see this one very clear. Can you see small membrane here? So the membrane membrane is again stained, and below the membrane if you see there is a white space which is the unstained part of the RBC. So that is the denatured hemoglobin. So the concept is here, the denatured hemoglobin after exposed to the oxidant drugs, so any oxidant chemicals, the hemoglobin gets denatured, and this hemoglobin, it won't take up the stain in the Leishman stain. Leishman, this is the Leishman stain. So it won't take up the Leishman stain here. That's why it appears as clear, and classically they call these cells as ghost cells, and to be specific they are called as hemi-ghost cells. Ghost means, in movies they'll see the white shadow is coming. So here also the cells are becoming very clear, like white, and not the entire cell, the half of the cell is becoming. That's why they'll call it as hemi-ghost cells. So that is that's why it looks as a bite. Here also there is hemoglobin which doesn't take up the stain, that gives the appearance of this bite cell. And this denatured hemoglobin, when we stain with the supravital stains, this is the supravital stain which is the new methylene blue or brilliant crystalline blue. Okay, so this is new methylene blue. When this denatured hemoglobin, when we stain with supravital stains, and this denatured hemoglobin will appears like this. Like this. So these are nothing but these are hinge bodies. Correct? These are hinge bodies. Clear? So now we talk about the hinge bodies. Let's discuss about the other hinge bodies in the PS. Other bodies in the RBC, which is the inclusions in the RBC. So what is this? What is this? What is this, sir? What is this thing you think? Yes, these are Howell-Jolly bodies. These are Howell-Jolly bodies. So how can we differentiate these from the hinge bodies? So, and we see this is the Leishman stain. So Howell-Jolly bodies, they don't need any special stain. They can be easily visible in the Leishman stain. That is the first difference. And you can see in the previous one, these hinge bodies, they always see, in everywhere they always attach to the membrane. Here they are always attached to the membrane. But the Howell-Jolly bodies, they will be seen inside the cell, inside the cytoplasm. That is the second difference. And the content. You know what is the content of the Howell-Jolly body? Yes, it is the nucleic acid, or it is the DNA. That is the content. But the hinge bodies are denatured hemoglobin. Correct? And the next picture you can see here, this is another inclusions. Yes, what is this? Yes, you are absolutely correct. These are Pappenheimer bodies. Correct? These are Pappenheimer bodies. And which stain we'll see here? Obviously, this is Pappenheim stain. But I want to know what is another name for Pappenheim stain? It is Wright stain, right? It's Wright stain. So these Pappenheim bodies, they will see in the Wright stain, and it's easy to identify because they are always in the multiple groups, right? They are always in the multiple. That's one thing. And what is their content? Yeah, their content is heme iron, right? Heme iron. So, and this heme iron, what is the special stain for this? Yes, you are correct. It's Pearl's Prussian blue. Right. So, in Pearl's Prussian blue, these Pappenheimer bodies will be highlighted, and normally they'll be seen. And here in the Pearl's Prussian blue stain, they will look blue color. But in Wright stain, they have this purple color. Okay, right. Then we'll go to the next. In HS, yeah, the first and foremost test what we'll do is OFT, right? So OFT is the first and foremost test, and the OFT, everyone knows this. These spirocytes are very fragile. Say they lyse at even higher concentration. So there is right shift of the curve. This is the normal. This is the continuous one is the normal one. This is the dotted one is the HS patient. So everyone knows this, but I want you to know the one concept which is tail concept. Tail concept. What is this tail concept? So in HS patient, if you see, this is the HS patient, this is the HS patient graph, OFT graph. If you see, the majority, around 60% of the cells, they are lysing at a concentration in between the 0.5 to 0.6. But if you see, if you trace this graph, here, can you see some cells, this area, so can you see, some cells, they are lysing at the starting of the test itself, like they are lysing at a 0.9, 0.8 concentration. Why? Everything are spirocytes, and majority 60% they are lysing here. What are these cells that are lysing at even at higher concentration? These are their microspirocytes. So how these microspirocytes are forming, what is their concept? That is because in HS patient, when these RBCs, the spirocytes specifically, the spirocytes, when they go into the spleen, and in the spleen condition, there is reduced pH, and they'll come into contact with macrophages. Right? They'll come into contact with macrophages. So, and this we know that in spirocytes, they already stressed RBCs. Their membrane is lost, right? So their membrane is lost and they're already stressed. But when exposed to these extreme conditions like reduced pH and contact with macrophages, they even more stressed, and they will lose some more membrane. They will lose more membrane, and they will become the spirocytes, microspirocytes. So they will become the microspirocytes. So these microspirocytes, which already they are very susceptible to lysis, that's why they are lysing at even at higher concentration. And all this concept, this is known as, this is the tail of the OFT, which this graph is extending as a tail, right? So this is the tail of the OFT, and this is because of the splenic conditioning. Splenic conditioning. This concept is known as splenic conditioning. So this all this occurs because of the spleen, right? So in HS patient, in severe patients, they will finally the definitive treatment is a splenectomy, right? So if the patient undergoes splenectomy, and this stain will disappear. So in splenectomy, this stain completely disappears. So this concept you should know. This can be a potential viva question. So they can ask why these cells are lysing at higher concentration. So you can tell these are microspirocytes and these are formed due to splenic conditioning. And when spleen is not there, and the stain will disappears. Okay. So the next test we'll do is in most of the laboratories, they won't stain all the slides, or like they won't make the slides for all the samples they'll receive. Like in our aims, like we'll get thousands of samples every day, and it's practically not possible, right, to see all the slides, to all the samples, to make the slides and see. It's not possible. So what we usually do in aims is like we'll only stain the slides where the CBC shows any abnormalities, like even the counts are abnormal and the CBC has shown some any flags have been raised. So that is the thing. So like I'm sharing my personal experience here. So like one time, like my technician called me and he showed me the CBC. So what I kept here, this is the CBC, exact CBC. So here see the WBC is absolutely normal, RBC is 4.9 million and hemoglobin is 13.7. Absolutely all the MCV parameters are normal, and sorry, this is a typo error, it is 183. So platelets are absolutely normal and there are no flags. See, RBC, everything is normal, there are no flags. And then he showed me this graph, the WDF graph, where I have highlighted the population here. You can see I showed me this graph, and also he showed me the another graph. This is a WNR graph. He showed me this graph, and I have highlighted already this population here. So he showed me this graph, and I said immediately, okay, make the smear. Then the young technician who is standing next to me, he asked me, ma'am, why everything is absolutely normal? There are no flags, and why are you telling to make a smear? Then yes, you guys tell me why I said to make a smear. Yes, anyone can try? Okay, I'll give a clue. Okay, the next one, this one. Yeah, what do you think? These are, now you can tell, right? This is malaria, right? And specifically it is Plasmodium falciparum. Yeah, the first junior most who cannot clearly identify this, for them I kept another picture, this one. You can see inside the RBC some purple colored dots, right? See, some purple colored dots are there. So this stain, so this is the same slide. This stain is the, which stain this one? This is Leishman stain. And which stain this one? Any guesses? Where this malaria has been highlighted clearly, right? Which stain? This is Giemsa stain. So this is an again MCQ potential question. Which is the best stain for highlighting the malaria? It is the Giemsa stain. Best stain to highlight malaria. Best stain to highlight malaria. So I'm writing here, so you can't see there. See there. So okay. So best stain is because why? Why this Giemsa stain is best? Because the stain pH is alkaline. Specifically, it is 7.2. The pH is 7.2. So when at this pH, the chromatin dots of this malaria, the nuclear chromatin dots, they will take up the stain nicely, and they will stain, and you can see clearly. So which will not be that clear in Leishman stain, because the Leishman stain pH is, what is the pH of Leishman stain? It is acidic pH, and it is exactly 6.8. So because of that, you can see very faintly where you can miss the junior most, they can miss this. So and we can for them we can show this Giemsa stain. That's the best stain where you can highlight. Okay, we are deviating from the topic. So I want you to guys to know this. So what is a which is one of the newer parameters in the Sysmex XN1000 series. So what is this? So if you see, if this kind of population which are highlighting, and in the WDF channel which is specifically plotted against side scatter versus forward scatter, that is one another thing you should see. Normally the WDF is plotted against side scatter versus side fluorescence, right? Side scatter versus side fluorescence. But if you want to see the malaria, you have to plot the against side scatter versus forward scatter, and you can see in this area, if you see the population, it is malaria. And again in this channel, the WNR channel, there is another WNR channel where you can plot in the side scatter versus forward scatter, or you can plot against side scatter versus side fluorescence. Okay, so in this channel you can see this is the population we highlighted. This is malaria. So, and this is a classical example, absolutely normal. And if this sample was run by a young technician who don't know this, he might have released the report as completely normal. Then it's erroneous, right? So you should teach your young technicians, because it's practically not possible to go and stand near the CBC machine all the time, right? So technicians will do all the work. So the technician should know, and we are fortunate enough to have great technicians in our institute in AIMS. So the technician showed me that, but I taught this the same thing to the young technician that day, and he learned. So next time he won't miss this. Correct? And I want to know what is this population, what I have highlighted here, what is this? And I'm giving clue, this is not malaria. I'm saying this is not malaria. What is this? Any guesses? This is NRBC. Okay, in the WNR channel, which is plotted against side fluorescence versus side scatter, this is the where NRBCs will come. And what is the cyan colored one? These are WBCs. WBCs except that is very important. WBCs except here you can see, I don't know how you can able to appreciate here. This is a very small yellow colored population is there. What is this? These are basophils. These are basophils, and these cyan colored ones are the WBC. Don't worry, we will discuss all these things in the subsequent slides. So I'm just telling here. So I want you to know, don't ever miss, even if the entire CBC is normal, teach your technicians to see the plots, and so that we can diagnose this malaria. We don't miss these conditions. Clear? And the next plot is in the flow cytometry. Yeah, most of the people, including me, will start interpreting from this plot only, from this plot, which is plotted against CD45 versus site scatter. But before this, there are three most important plots are there in the flow cytometry, which most of us we don't care about those plots, but they are very important. And you know, without those three plots, you won't get this plot only. And because see here, this plot is like this population are plotted against CD45 versus site scatter. What is this population? You can see here, it was written as viable. So these are viable cells which are plotted against the CD45 versus site scatter. What is this viable cells and how these viable cells are plotted? So we should know that, right? So because without those three plots, entire flow is, it's useless kind of. But most of the people won't give an attention to that. So but we won't miss that, right? We will know those plots. So what are those plots? So the first plot here you can see, and this is the first and foremost plot what you will see in the flow cytometry, which is the plotted time versus site scatter. Okay, and this plot, it indicates the acquisition of the sample, acquisition or acquiring of the sample. So acquisition means nothing but we were collecting the cells from the sample and we were calculating the events. So see, single one dot, each dot is a cell, each single dot is a cell. So we are counting the cell, and minimum events we should need for a proper flow cytometry is minimum is 50,000. It can be maximum till 2.5 lakh, but minimum is 50,000 counts we need. So and this plot, this graph, it indicates the acquisition of the sample, and if the sample has been acquired, the cells are acquired properly or not, it indicates that. How it indicates? If the graph is like this, see, the dots are coming continuously, right? Continuously, there is no gaps, there is no breaks, and no sudden stoppage, right? So if the graph is like this, then it is normal acquisition. That means, and I already said in the previous slides, right? What is this? The acquisition indicates what is that? Which component of the flow cytometry? It is the fluidics component, right? We already discussed this. So fluidics component. So that means the acquisition is normal, means the fluidics component is absolutely normal. The tubing systems, they are absolutely normal, right? And here I kept the same graph like in another flow, the same graph like time versus site scatter. So here, can you see? Here some cells are coming, again there is a break, and here some cells are coming, again break, some cells. So if graph is like this, this is abnormal acquisition. The acquisition is not normal here, and you should never interpret the flow when this acquisition is like this. If you don't know, if you don't see this plot and you start interpreting from the CD45 versus site scatter, then whatever you report the flow, it's absolutely wrong. So always start from this time and acquisition plot, this time versus site scatter plot. You have to make sure that acquisition is proper. So what we do when this is coming like this, that means the fluidic system is abnormal, right? So what we have to do? We should not report this flow, and we have to rerun the flow. And again, before rerunning, what we have to do? We have to clear the tubings. Right? Clear the tubings. How will clear? We'll pass the distilled water. We have to clear the tubings. We have to make sure the tubings is intact. So then only again rerun the flow. See, this is very most important graph, right? Which we tend to miss, right? And next, the second one, the second plot, which is there in the flow cytometry, is this one. This plot plotted again forward scatter area versus height. Okay, so this plot, what it detects, what it indicates, this plot shows the singlet population. So, like, yeah, we already discussed. So, there is a principle for what is that? What is that? Yes, hydrodynamic focusing. So, what is that? We will just now discuss. Hydrodynamic focusing is that it makes sure that each cell, at a time, one cell passes through the laser light, and laser light will hit only one cell. So, even though we use this hydrodynamic technique, sometimes there is doublets and triplets is still possible. Okay, so that's why we have made this gate to separate the singlet population from the doublets and triplets. Okay, how will we separate? So for that we have to understand this. See, if a laser hits a singlet population here, it gives an impulse, right? That it gives us some height and we have some width and they have some area. So even one single cell comes, this is the height and area, height and width, and this is the area. When doublet population hits by the laser, the height might be same, but the width will be increasing. Because of the increase in width, so the area also will increase. right? So that's why we are making use of this concept here. So where we are plotting against area versus height. So you can see here, this is the gating, that is an electronic window. Gating is nothing but electronic window, right? So we have created here a window surrounding this, and you can see some dots here, right? You can see here, right? So these dots, they're lying outside this window. It's not like lying outside, we didn't gate it, because see, they have more area, the area is more, but even though they have same side, same height. See, this population has this height and they have same height like this population, but they have more area. That indicates these are doublets or even triplets. Okay, that's why we have created a gate surrounding only the singlet population, leaving these doublets so that we can interpret clearly. Why we have to separate them? Because let's say, for example, this cell, this is B cell and this is T cell. They got attached together, and when a laser hits this, B it has own immunophenotypic characteristics, and T cell, it has own immunophenotypic characteristics. So what will happen? This population, if we include in the gating, it shows both CD19 positive and CD3, cytoplasmic CD3 positive. So then we'll label it as mixed MPAL, mixed phenotypic acute leukemia. We'll misdiagnose it as MPAL. Okay, so this should not be done, right? It's very erroneous. That's why we have to separate this singlet population from the doublets and triplets. So this is another important graph, because we can misinterpret the entire flow report, right? Then, and the third most important graph here is the forward scatter versus side scatter. Okay, so this gate or this plot is viability gate or viability plot. Okay, so here we have to, we have to interpret only the viable cells, not the dead cells or debris. So that's why we have to create this gate. And if you see here what we have gated, only the viable cells have gated against the CD45 and side scatter, and this is the same viability gate what we are talking now. Okay, so here how can we say the cells are viable? If the cells have more forward scatter and less side scatter, then those cells are viable. So he can see here these cells, can you see here this population which I am getting here? See, I am making a these cells, if you see, they have high side scatter, right? They have high scatter, but if you see the side, high forward scatter, high forward scatter, but if you see here, they have less side scatter, right? But if you see these dots, which are having high side scatter and low forward scatter, so these are dead cells. These dots are dead cells, and these only the viable cells. These are the viable cells. So these are the most important plots we should never miss, because if you miss this, the entire flow report may be erroneous. Okay, so pay attention to this. Then we'll go to our next plot. Okay, this is our next graph. Okay, first we'll go in the sequence. So first we'll see the area. It is in between 1 to 4 million, and the baseline is straight, and there is no up and downs. It's straight, and the peaks are sharp and symmetrical. So we can interpret the HPLC, right? Yes, always first you see should interpret or not. Okay, then what is here? What is abnormal here? S window is more than 50%. Okay, S window is more than 50%. Then what is raised? Again, F, right? F is raised here. So what is this diagnosis? Yes, it's easy. What is the diagnosis? It is sickle cell anemia, right? Sickle cell anemia. Okay, then the next graph. Again, the area is between 1 to 4 million, baseline is straight, and the peaks are sharp and symmetrical. So we can interpret the HPLC. Again here, what is there? S window. Again, it is more than 50%. And what is this? What else is increased here? Some 31.1%. What is this? L11C. Yeah, what is this? L11C indicates, we just discussed before the 2-3 plots. This is nothing but HBF, right? So if the HBF is more than 16.5%, it elutes in the L11C window, right? So this is nothing but this is HBF. So the HBF is increased, again S window is increased. So what is this? Again sickle cell anemia? Did I keep two slides of sickle cell anemia? So no, never ever interpret the HPLC without looking at the CBC. I am again repeating the same line. Okay, never ever interpret the HPLC without looking at the CBC report. Can you see the CBC report here? See, the hemoglobin is absolutely normal, hematocrit is normal, RBC, everything, all parameters are absolutely normal, but the S window is more than 50% and HBF is increased. Then what is the diagnosis? What is the diagnosis? Yes, it is double heterozygous, or we can say double or compound heterozygous. For compound heterozygous for what? For HBS, because S is more than 50% and F is also increased, so it is HBFH. So, and if you see the previous one, can you see here? Now you did the mistake here again, just seeing the HBS window and F directly we said sickle cell anemia. We didn't see the CBC. See the CBC here. See, HB is severe anemia is there, right? Severe anemia very much reduced, and hematocrit is reduced, RBC is reduced. So now we can clearly say it as sickle cell anemia. So here what is the take home message? If you see in the HPLC, if you see increase in HBS more than 50% and increase in the HBF, and if then just don't jump and say it as sickle cell anemia. Now what is this one? What we have to see here? CBC is the key. Never ever miss this. Never ever do this mistake. Just even though in questions also the first option will be sickle cell anemia. Will aram so we can keep it off, right? Happily we can say yeah, but that is the tricky question. That is, there is a trap. We don't fall in trap, right? So we should always see the CBC where in this where HBS is more than 50% and HBF is increased. CBC is the key. When CBC is absolutely normal, then it is double or compound heterozygous for HBS and HBFH, and if the CBC shows severe anemia, then it is sickle cell anemia. Clear? Can we go to next plot? Before we go into the topic with different patterns of bone marrow involvement in various various disorders, I just want you to know the basic, like the normal appearance of a bone marrow. Everyone will teach the abnormal patterns and all, but you should, when you don't know the normal, how can you diagnose it as abnormal, right? So but first we'll discuss the normal, then we'll discuss the abnormal. Okay, so yeah, so this I made it as a, so that you can see the, I made it zoomed it so that you can see clearly the all the cells. So here this is nothing but trabecular bone. It's already written here. This is trabecular bone, and this, what is this space next to the trabecular? This is the paratrabecular space. PTS paratrabecular space. Okay. Then what are the, when you just in low power also in 4x only, we'll see the big cells. What are those big cells? We can clearly see them. These are megakaryocytes. You can see this big cell, right? These are megakaryocytes. So and these are other granulocytes and erythrocytes. We'll discuss one by one. So first point is, see, in the low power itself, we can identify these megakaryocytes. And what is the, I want to know, what is this normal location of these megakaryocytes? What are the normal location of these megakaryocytes? Normally, these megakaryocytes, yeah, they're the mature ones, they'll see in the center. That is not the point. These megakaryocytes, they will normally present close to sinusoids. This is the point I want you to know. Close to sinusoids are any arteries. Why? Because what is their function? Megakaryocytes, they should release the proplatelets and platelets by their cytoplasmic fragmentation, right? So platelets, they need, finally the platelets reaches the blood. That is the reason they always lies close to sinusoids and arteries. This is the basic point. So one is done. Then the granulocytes. So the maturing granulocytes and all will be seen. In the paratrabecular space, what cells will be there? In the paratrabecular space, what cells? All the blasts or immature cells. It can be myeloblast, it can be erythroblast or megakaryoblast, but all the blast cells will be located in the paratrabecular space in this region. Okay, and as they mature, they will come towards the center. Then what are the next cells? The erythroid cells, right? So if you see here, you can make out the difference. Some cells are darkly stained, right? Can you see these cells are darkly stained and these cells are lightly stained? You can see here also some are darkly stained, some are lightly stained. So the lightly stained ones are the granulocytes and their precursors, and the darkly stained one, these are the erythroids. And I want to tell you to one more thing. If the darkly stained cells, there are two cells, not just erythroids. There are one more cell is there, which is I'm sorry, the erythroids, and one more cell it is darkly stained, they are lymphocytes. To differentiate them. So the erythroids, as you can see, they have a clear halo surrounding it. Can you see? There is a clear halo. Most of the cells, they are clear halo. If the cells have a clear halo surrounding them, then they are erythroids. Let me take another color. I am not able to see here. Okay, so they are erythroids. If there is a clear halo surrounding them, can you see here? See, there is a clear halo here. Clear halo here. You can appreciate it, right? So if there is a clear halo surrounding them, then they are erythroids. And lymphocytes, they don't have any clear halo. They just like dot. Like classically they will say like a bindi. Like they don't have any clear halo. There's like just dots. So this is another concept I want you to know. Okay, now we'll discuss the abnormal ones. Okay, so what you are seeing? This is the trabecular bone. And what are these? The big ones. You can see clearly, right? What are these? The big cells always. These are megs. So any abnormality you are seeing? Any abnormality you are seeing? Where it is located? See, this is the meg. Where it is there? Next to the trabeculae. That means in the paratrabecular space. It is located. Which is normal? Is it normal? No, right? It usually should be close to the sinusoids. Correct? But it is coming and lying at the close to the trabeculae, which is in the paratrabecular space. And one more thing. Here, if you see, there are 1, 2, 3, 4 megakaryocytes. They are showing clustering. Right? And if you see this megakaryocyte, is the nucleus normal? Is it looking normal? See, this is like as if someone is dragged its nucleus. It is like this, and it is like multiple lobulated. Here it is very clumped. So the nucleus is also not normal. So there is atypia, right? There is atypia. So there is atypia and there is abnormal localization and clustering. All this pointing towards which one? Yes, you know the diagnosis. Yes, you are correct. It is PMF, primary myelofibrosis. So which will have megakaryocyte clustering, megakaryocytic anisocytosis, and abnormal localization, especially the paratrabecular localization. All these things are pointing towards the diagnosis PMF. See, if you know the normal and abnormal is very easy. It's like a cakewalk. Okay. Then next, this is the next slide. I'm highlighted here. What is this? What are these cells? Okay, we will describe it. What are these? They are looking very immature to me, and they know they have various sizes and shape. There is anisocytosis, so that means there is atypia, right? They have very immature chromatin. So these are nothing but blast, correct? And we are just now I said where the blast should be located. They should be located close to the trabecular in the paratrabecular space. But what they are doing here? They should not be here, na? And even they are here and they are in clusters. Can you see? They're in these cells have 7 8 cells. They're in clusters. That is abnormal, right? What is this called? What is this called? Yes, anyone? What is this called? This is ALIP, which is abnormal localization of immature precursors. Okay, abnormal localization of immature precursors. ALIP. See, again, if you know normal, abnormal is very easy. Okay. Okay, next we'll go to another one. Yeah, I want you guys to know this. So see, what is this? What do you think? Are these erythroids? I said darkly stained ones. These are all lightly stained. These are darkly stained ones. Darkly stained ones. There are two things. Either it can be erythroid or lymphocytes. So what do you think? What do you think this? Is this lymphocytes or erythroid? These are lymphocytes. Because can you see any halo around them? See, they're just like dots, right? They're like dots. So these are lymphocytes. So now here comes the big question. Or these are normal benign lymphoid follicle? Like that means they're aggregates, right? They are all as forming as aggregates. So it is a benign lymphoid follicle or it is a malignant one and a lymphoma. So that is a big question, right? So what will do next? What will you do next? Yeah, IHC will do that. Everyone will say IHC that comes, but first we should confirm with morphology, right? We should know the morphological points. We should become a good morphologist first. IHC, it's not possible all the times to have an IHC, correct? So what are the findings? What are the points that favors it is benign and what are the points that favors malignant? We'll know that, okay? The first point and first and foremost point, can you see this is the lymphoid aggregate and it's very small, right? Right? Is it small? This much only. It's a small one. The first point is there will be small in size. Which one? The benign follicles. These are the benign points. I'm writing here. These are benign points. They should be there small in size. Most of the times they are small in size. And if you see, I kept another slide for a comparison. See, these are also some aggregates. Again, lymphoid aggregate, right? Can you see? And can you see this? How much big it is? So the malignant ones are larger in size. First thing, first point. Okay, these are small in size, and I can write here. These are large in size. And the second point. Can you able to clearly demarcate this one? See, I can clearly draw a line, right? I can clearly draw a line. So they are well circumscribed. Which one? Benign ones are well circumscribed. But if you see, yeah, it is also looking like little circumcision. But if you see this side, it's invading here. Can you see? These cells are going here. It's invading. So the malignant ones, yeah, that's a normal feature. Invasion or infiltration. So that's a normal finding. And the third most finding and very, very important finding I want you to know is the location. The location of this follicle. Can you see where is this follicle? It is in the center of the marrow, right? It is located in the center of the marrow. But where this lymphoid follicle is located? What is this? Trabecular, right? So it is located in the paratrabecular space. Correct? It is located in the paratrabecular space. So if it is located in the paratrabecular space, then it is abnormal. Okay, and yeah, most of the times it's a classical for the which lymphoma? Paratrabecular localization, which lymphoma? It is follicular lymphoma. Yes, for CLL also we can ask them CLL, interstitial location, nodular location, CLL. It's still not in, it's in the interstitium, like in the center of the marrow, but it is malignancy. Now you can say that. Yeah, for that we should know another point. The next point, which is the pattern of involvement, the patterns of involvement of lymphoid follicle in bone marrow. You should know the patterns. Then you can understand the concept of why CLL and benign. What is the point? So how many patterns are there? Anyone know? 5 patterns are there. Okay. So what is the first pattern? The first pattern is predominantly T cells. That means if the lymphoid follicle contains predominantly T cells, that is pattern 1. Then pattern 2, there is mixture of B and T cells. That is pattern 2. Then pattern 3, which is T cell core surrounded by B cells. This is pattern 3. And these 3 patterns are their diagnostic, or I can say it is classical for a benign lymphoid follicle. Benign lymphoid follicle. Okay. So if you like this, yeah, we can't tell in morphology this, as you said before, we have to do the IHC, then only we can know the pattern. So if after doing the IHC, the basic IHC we'll do if to know it is a lymphoma or not, that's CD3, CD20, the first panel, right? So if predominantly the lymphoid follicle composed of predominantly T cells, or if it is mixture of B and T cells, or if the T cell core is there surrounded by the B cells, and these 3 patterns are diagnostic or classical for benign lymphoid follicle. So what are the other 2 patterns? Pattern 4, which contains predominantly B cells. And what is the pattern 5? There will be B cell core surrounded by T cells. B cell core surrounded by T cells. And these 2 patterns, they are diagnostic for malignancy or lymphoma. So this you should know. That's why now you understand. In CLL, they are interstitial collections. Yes, they are in the center of the marrow. But what they are composed of? In CLL, what they are composed of? They are completely B cells, right? Which is a pattern 4, and it is characteristic of malignancy. So now you understand. It's now the most of the times paratropical localization indicates lymphoma. Even if it's center, now you have to look for the pattern. So if the pattern 4 and 5 is there, then it's a malignancy, not benign. Okay. So yeah, now we are done with the morphological findings, where again I am repeating. So they are small in size. The benign ones are small in size and they are very well circumscribed, and their location usually in the center of the marrow. Where the malignant ones, they are large in size and they have infiltrating borders, and they have classically, like predominantly they have paratrabecular localization, and this paratrabecular localization, it is classical for follicular lymphoma. Okay. Then okay, so now we came to the IHC. Based on the patterns, based on the IHC only we have to identify the patterns, right? So now, yeah, we have discussed that, like we have suspecting here, yeah, in this one we thought that, yeah, this paratrabecular localization is follicular lymphoma. So what is the classical IHC for follicular lymphoma? What is the classical IHC? Yes, I already showed you. So the classical one is, it is BCL2, right? So this BCL2, as the same picture here, you can see the trabecular, these all the cells, they have positive, they have taken up the BCL2. So we are happy. Yeah, there we thought it as follicular lymphoma, and it is came positive, BCL2 came positive. So we are happy that we are diagnosed are correct. But what happened to this? See here, what happened to this? We are thinking till now it is benign lymphoid follicle, right? Because all the points morphological just now we discussed, but it again it has taken the BCL2. Why? Are our morphological points are wrong, or the IHC BCL2 IHC did the technician did something wrong? What is this? So for this, we have to understand one more concept, which is this one. So here, I would like to, I would like you guys to think the lymphoid follicle as in the form of an egg. Think the lymphoid follicle in the form of an egg, and if you cut the egg, like in this egg slicer, cut the egg, you will get the pieces like this, right? So what is the first piece? When you cut here, what is the first piece you will get? Is the first piece what you got here? Only the white one, right? Only the white you got. But later in the subsequent slices, you got the yolk. Correct. In the same way, you imagine the benign lymphoid follicle in the form of egg, where the white is the white part is the mantle zone, and the yolk is the germinal center. Okay, imagine like that, germinal center. Imagine like that. So when we did the first section, what we have seen here, I the same picture I kept here. What we have seen here, this is nothing but only the white part of the egg. Okay, are you getting me? Right? Only the white part of the egg we have seen. Nothing but this is mantle zone only. And we know that BCL2, we already discussed in the previous slides, mantle zone marker is like BCL2 comes positive, normally positive in mantle zone B cells, and one more, what is that? Paracortical T cells, right? So this is nothing but, we are seeing it's nothing but is the mantle zone. And in the subsequent sections, where in the subsequent sections, here this is the germinal center. Now the yolk came out. Okay, the germinal center came out. So here, see the BCL2 marker, again it is negative, and it is surrounded by the mantle zone B cells, which are again positive. Now you understand? So just if you see the BCL2, don't jump and tell it as follicular lymphoma. No, never. It might be a normal mantle zone. In the subsequent sections, you can see the general center coming up. But yeah, it's not possible to, always to go for a deeper section. So how can you avoid that problem? So in follicular lymphoma, what is another marker? What is another marker? Important marker. What is that? That is CD10. I already kept here. That is CD10. Right. So the same picture, if you see these cells, they are BCL2 positive and these cells are CD10 negative. So when I see this, I can confidently I can say that these are mantle zone because CD10 are negative. CD10 is the germinal center marker, right? These cells which are taken BCL2, they are CD10 negative. That means these are not germinal center cells. These are mantle zone cells. That's why they are CD10 negative. So this is the take home message. What is the take home message? Without seeing that CD10 interpretation, don't ever jump to follicular lymphoma. And in that also, as the BCL2 cells are taking the BCL2, whatever the BCL2 positive cells are, those are taking the CD10 in IHC or not. If they are not taking the CD10 IHC, then it may be the mantle zone, the normal one. Okay. If the BCL2 positive cells, they are taking the and those cells again they are taking CD10 positive, then we are seeing the case of follicular lymphoma. Okay. Okay, then, and I want to ask you one question which is out of we will discuss in the lymph node section. But I want to ask which follicular lymphoma is BCL2 negative? Anyone? Which follicular lymphoma BCL2 negative? BCL2, which is characteristic marker, right? BCL2 negative follicular lymphoma. Anyone? It is pediatric follicular lymphoma. Okay. Okay.
Download our PathoElite app. You can see the courses like this. See the Pathology Masterclass and DM Oncopathology, Elite Q Bank, Hematopathology. So I'll show the Elite Q Bank now. So once you open it, you can see we made the 3 categories: Hematopathology, Oncopathology and General Pathology. I'll show you the Hematopathology now. So in the Hematopathology, I separated it into benign, malignant and hemat techniques. I kept the hemat techniques separately because in every exam you will get 2-3 questions, at least 1 question regarding flow cytometry and HPLC, and even for the final year pathology students, exam going PGs, the HPLC and flow cytometry is a must spotter. So that's why I separated these hemat techniques, so you can do and clarify your doubts in that. Then I'll show you the benign disorders. In the again benign disorders, I separated into RBC, WBC, platelet and coagulation disorders. So you can see they everything like is a sorted way. So if you read one topic in RBC, let's say miscellaneous I'm taking. So if you read one topic like sideroblastic hereditary hemochromatosis, anything, so immediately you can do the questions and you can gain the confidence.
Similarly, under the oncopathology section, we can see there are different topics, as you can see. Say for example, we will go to bone topic. So under the bone section, you can see videos are there. I want you to go through the videos. Say 5 videos are there. I want you to revise through the notes provided in the ebook section and finally do the practice MCQs. Under that also we have categorized like benign, malignant. Say for example, malignant one. Let's just start the quiz. And you can see the first question, say a young child with a onion skinning periosteal reaction and a small round blue cell tumor. The answer is quite obvious, right? Ewing sarcoma. So what is the fusion in Ewing sarcoma? We know the answer, option C, right? But unless and until you click the correct options, the explanation won't come. So that's the added feature we have created here. And in the explanation sections also, not just the correct options, but also we have given explanation regarding the incorrect option so that you can revise all 4 options simultaneously.